Hey, I am Dr. Dillon. Imagine your blood pressure is finally under control. Your last reading was perfect. Your doctor is completely satisfied. Amlodipine, one of the most widely prescribed cardiovascular medications on the planet, is doing exactly what it was designed to do. Now imagine something you do every single day quietly working against that medication. Not a rare genetic mutation. Not something that requires advanced laboratory testing to uncover. Something ordinary, something you very possibly did this week. I have been practicing cardiology for over 2 decades, and I can tell you with absolute certainty, the complications I treat most frequently with amlodipine are not caused by the drug itself. They are caused by the biomechanical and biochemical changes happening around it, completely undetected by the patient. Today, I am going to walk you through 5 of these hidden interactions. But you must stay until the very end, because there is a 6th factor I have deliberately left off the main list that sends more of my patients to emergency cardiac care than almost everything else on this list combined. I will reveal it after we break down the first 5. Do not skip ahead. Let us begin. Factor 1. The CYP3 of 4 enzymatic shutdown factor, number 1, grapefruit. I know you have heard this warning before. Perhaps you dismissed it as a minor dietary overreaction. Please, do not dismiss it this time. Your liver contains a critical metabolic enzyme known as CYP3A4. Its physiological job is to metabolize amlodipine, to break it down at a highly controlled, predictable rate so the drug maintains a precise, safe, therapeutic concentration in your bloodstream. Your exact dosage was calibrated under the medical assumption that this enzyme is functioning normally. Grapefruit contains a potent class of organic chemical compounds called furanocoumarins. These compounds bind directly to your CYP3A4 enzymes and completely deactivate them. When this enzyme pathway is blocked, amlodipine cannot clear your system at the expected rate. It accumulates rapidly. What was once a carefully calibrated therapeutic dose begins behaving inside your body like a massive overdose. The clinical symptoms of this accumulated spike are severe. Profound dizziness, pounding vascular headaches, intense flushing in the face and chest, a racing or irregular heart rate, and a drop in blood pressure so sharp it can instantly compromise your balance. Here is the precise detail most people are never told. The enzymatic blockade caused by furanocoumarins can last for up to 72 hours after a single glass of grapefruit juice. That is 3 full days of impaired drug metabolism from one morning beverage. Therefore, the clinical instruction is absolute. Remove grapefruit entirely from your diet while taking amlodipine. Oranges, lemons, limes, and tangerines are completely safe. Grapefruit is the specific biological problem. Note that pomelos and Seville oranges carry an identical risk and must also be avoided. Factor 2. The rebound hypertensive spasm. Factor number 2. Stopping amlodipine suddenly. This is precisely where the most catastrophic cardiovascular crises in my practice actually begin. People halt this medication for numerous reasons. They feel excellent and assume their hypertension is cured. They run out of tablets and delay their refill, or they decide they want to manage their blood pressure through diet and lifestyle alone. While lifestyle modification is a conversation I highly encourage, it is never a decision to make unilaterally overnight. Let us look at the underlying physiology. Amlodipine functions as a calcium channel blocker, directly relaxing the smooth muscle walls of your arteries. Over months of compliance, your cardiovascular system adapts to this baseline. The blood vessels settle into a consistently open, dilated state. When you abruptly remove the drug, those vessels do not gradually adjust. Instead, they can respond with a violent sudden contraction, a severe rebound vascular spasm. This is medically termed rebound hypertension. It does not just bring your blood pressure back to where it started. It can drive your readings to dangerous extremes, frequently reaching 200 systolic or higher. At these hyper-elevated levels, your acute risk for ischemic stroke, hypertensive encephalopathy, and acute kidney injury skyrockets. If you wish to lower or discontinue amlodipine, it must be done through a structured, medically supervised tapering schedule to allow the vascular smooth muscle to safely recalibrate its tone over several weeks. Feeling completely healthy on this medication is not a signal to stop. It is the definitive proof that the medication is working exactly as intended. Factor 3. The hydrostatic pooling crisis, prolonged motionless standing. Factor number 3. Prolonged standing without movement. This critical lifestyle variable is almost never discussed during a standard prescription consultation, but it carries significant physiological consequences. Because amlodipine successfully dilates the peripheral arteries throughout your body, it naturally increases blood flow to your lower extremities. This is highly effective for lowering systemic pressure, but a serious issue arises if you stand perfectly still for an extended duration, such as waiting in a long queue, commuting, or attending an event. Without movement, gravity continuously pulls blood downward into those highly dilated vessels. Your calf muscles, which normally contract during walking to act as a venous pump to force blood back up to your heart, remain completely inactive. Blood pools heavily in your lower legs and feet. The immediate visible result is severe ankle swelling, known as peripheral edema. However, the hidden danger occurs when you suddenly sit or lie down after this prolonged pooling. The blood sequestered in your lower extremities redistributes rapidly, causing your central blood pressure to plummet. This triggers sudden, severe orthostatic dizziness or immediate fainting. The clinical solution is simple tracking. If you must stand for more than 15 minutes, keep your venous pump active. Shift your weight continuously from foot to foot. Perform subtle toe raises to contract your calves, or utilize isometric calf tensing. When you do finally transition to a seated or flat position, move deliberately and slowly to allow your circulatory system time to normalize. Factor 4. The pharmacological opposition. Factor number 4. Non-steroidal anti-inflammatory drugs, commonly known as NSAIDs. This includes ibuprofen, naproxen, diclofenac, and high-dose aspirin. Because these medications are readily available over the counter, their profound interaction with blood pressure regimens is drastically underestimated. The biological mechanism is highly adversarial. NSAIDs act on the kidneys, forcing them to retain significant amounts of sodium and water. This dramatically increases your total circulating blood volume, raising the hydrostatic pressure against your arterial walls. Simultaneously, NSAIDs aggressively inhibit prostaglandins, the foundational signaling molecules responsible for keeping your blood vessels dilated. When prostaglandins are suppressed, your blood vessels constrict. Amlodipine is trying to dilate your vessels and balance fluids, while the NSAID is forcefully constricting your vessels and retaining fluid. They are in direct pharmacological opposition. Clinical data shows that adding regular NSAID use to an antihypertensive regimen raises average systolic blood pressure by 5 to 10 millimeters of mercury. In vulnerable individuals, the spike is far greater, completely destabilizing their blood pressure control without the patient ever realizing a common painkiller is the culprit. For pain management while on amlodipine, paracetamol or acetaminophen is the preferred alternative to discuss with your doctor, as it does not interfere with renal sodium handling or vascular prostaglandins. Factor 5. The cosmetic deception, panicking over ankle edema. Factor number 5. Quitting amlodipine because your ankles are swelling. Peripheral edema affects between 6% and 12% of patients taking standard doses of amlodipine. Because amlodipine dilates the entry arteries into your capillaries far more effectively than the exit veins, it creates a localized fluid pressure imbalance. This forces clean fluid to leak out of the microvessels and pool into the surrounding soft tissues of your lower legs. By evening, your shoes may feel tightly constricted, and your legs may feel immensely heavy. Frightened by this sudden physical change, many patients panic, assume their heart or kidneys are failing, and quietly stop taking their pills without notifying their physician. I need you to understand this clearly. In the vast majority of cases, this localized swelling represents absolutely zero danger to your heart, your kidneys, or your central circulation. It is an uncomfortable cosmetic side effect, not an internal medical emergency. The fluid is trapped in the soft tissue of your ankles, not building up inside your lungs or around your heart. However, panicking and stopping the drug immediately triggers factor number 2, rebound hypertension, and a massive pressure spike. If ankle edema is diminishing your quality of life, stay in communication with your doctor. We have highly effective, established tools to resolve it. A minor dose reduction, a transition to an alternative calcium channel blocker, or the addition of a targeted low-dose diuretic can eliminate the fluid entirely. The case study and the critical 6th factor, the pre-procedure fasting trap. To see how these factors can compound into a life-threatening crisis, consider a recent 71-year-old patient of mine named Reginald. He had been stable on amlodipine for 3 years. Then, Within a 3-week window, 3 factors collided. He was prescribed ibuprofen for joint pain. His family introduced daily grapefruit juice into the household, and noticing his ankles swelling as a result, he quietly stopped taking his amlodipine to see if the swelling would go down. His family found him collapsed on the kitchen floor. Upon emergency admission to my clinic, his systolic blood pressure was a staggering 217 millimeters of mercury. It required 4 days of intensive inpatient stabilization to safely bring his cardiovascular system back under control. It was a terrifying, deeply disruptive event for his family that was entirely preventable. This brings us directly to the 6th and final factor, the one that triggers acute emergency interventions more frequently than almost any other variable combined. Failing to disclose that you are taking amlodipine to every single healthcare provider before undergoing dental work, minor surgery, or any elective medical procedure, especially those requiring fasting. Fasting rapidly depletes your circulating fluid volume. When you combine a depleted fluid volume with the profound vascular dilation caused by amlodipine, your heart suddenly has far less resistance to pump against. Systemic blood pressure can plunge to dangerously low levels. When you add local anesthetics, mild sedation, and the natural physiological stress response of a procedure, it creates a volatile, unpredictable circulatory environment. If your surgeon, dentist, or nurse does not know you are on amlodipine, they cannot accurately anticipate or prepare for this profound drop. The remedy takes exactly 5 seconds. Explicitly declare that you take amlodipine on every medical history form and verbally state it to every provider before any clinical intervention. This simple act fundamentally alters their monitoring and fluid protocols, ensuring your absolute safety. Take care of your cardiovascular system. It works harder, more precisely, and more quietly than most of us will ever fully appreciate.